और अभी ये स्ट्रीमिंग इसकी हो रही है
जी।
तो
इसको लाइट्स को थोड़ा डिम करेंगे तो थोड़ा क्लियर नज़र आएगा। ये लाइट्स और डिम होंगी सर, ये लाइट्स और डिम कर सकते हैं ये लोग? जी, थैंक यू सो मच। अस्सलाम वालेकुम, बिस्मिल्लाहिर्रहमानिर्रहीम। My name is Dr. Amir Khan, and I am an associate professor in geriatrics. For those who do not know geriatrics, it is the field of science that deals with the old people, medical science. Gerontology, on the other hand, is the process or the field which is involved with the study of old age. So there's a little bit of difference in that. So I left this country like 20 years ago and went to United States to get higher education, and I did my training in family medicine, and in geriatrics I did my fellowship. So I'm board certified in family medicine and geriatrics. So I will keep English as the main way of communication over here, but I can speak Pashto and Urdu fluently. So today I would thank you for allowing me to talk over here. I'm very happy this is my first talk today, and thank you all for coming here and joining us. I hope we have more people who will join us later. So there are several topics that we can talk about, but the one that I picked up today is the annual geriatric visit. So we call it the annual wellness visit in the United States. That means that once a year the geriatric patient comes in and he gets an annual visit. What does that mean? Briefly, if you have any problem, you go to the doctor and he concentrates on that problem. So the time that he uses, he consumes that time and concentrates on that one or two problems that you describe. The geriatric annual visit, on the other hand, just continues to work on the general well-being of the patient. And so in that we cover several things, we cover several topics, and we make sure that the patient is doing great. So saying that, let's move ahead. So the definition of geriatrics and gerontology. So geriatrics, we can see it's a branch of medicine or social science that deals with the health and care of the old people. So the old people, or the elderly people, that's what we call them, is a term that we use for patients who are 60 and above. Mostly we use the cutoff of 65, but generally I believe that 60 and above is the time frame where we can call them as a geriatric patient. The term geriatrics comes from a Greek word called as geron, meaning old man, and the iatros means healer. So that forms the word geriatrics, healer of the old man. Gerontology, on the other hand, is mostly the scientific study, as I mentioned, of old age and the process of aging and the particular problems of the old people. So it's more like a physiological term, and geriatrics is more like a medical term. So a little bit about the global trends and demographics of geriatrics. So it is very important that we identify the upcoming problems, the way people are getting older, and the life expectancy of the people is increasing. So it is important for all of us to identify the issues that are going to come forward with that, and also how to deal with that. So the population aging can be defined as the change in the age composition towards older age. So as the mortality and morbidity, mostly the mortality is decreasing to a certain extent, the life expectancy is increasing. So the trend of the aging population is going towards older patients. The baby boomers is the term that has been used in the United States. That indicates the patients who are, or the people who were born between 1946 and 1964. So those baby boomers are now in the geriatric population in the United States, and the amount of medical care that they need and the amount of medical care and the expenditure that comes along with that is important for everyone, whether it's personal, on the personal level or on the government level, to identify that and make sure that they can take care of that. In 2018, the population of 25% of developed regions and 10% of developing regions was greater than 60. And in 2050, 25% of the global population will be greater than 60. So that is a great number of patients, and the upcoming burden which is going to be on the government and on all the healthcare providers, and we have to be ready for that. Aging is a strong risk factor for most chronic diseases associated with expanding healthcare expenditure and also the utilization of resources. So we should be ready for that. So what is a geriatric assessment? It can be done in a clinic. It can also be used in the emergency room, in the nursing home, home care. So those are the different places where we interact with the geriatric patient, and we want to make sure that the providers, that includes the doctors, the nurses, the physical therapists, the occupational therapists, should have the sense and the skill and the education how to deal with the geriatric patient. And that is very important that we teach them how to do that. So what is a geriatric assessment? It is a multifactorial or multifocal approach to the care of the older adult. The goals of care, the level of frailty, the time treatments, and the interprofessional team is an important aspect of geriatric care. These are all the geriatric syndromes, and each one of these is a topic itself. Delirium. Delirium means acute confusional state. The common causes of delirium are dehydration, pain, infection, hypoxia. Those are the most common reasons that we see delirium. Medication side effects. So it is important that we identify that the patient is delirious, and it is a very complex issue. Delirium happens in the ICU, delirium happens at home, delirium happens in the emergency room, and unless you identify that the patient is delirious and take care of the problem, it has got high morbidity and mortality. Dementia, there are many types of dementia, and I believe we have a neurologist over here who might tell us about dementia. But dementia, the most common one that we see is the Alzheimer's, vascular, and the mixed dementia. We also have dementia due to Lewy body. I'm not sure what type of dementia is more prevalent over here, but probably vascular or mixed dementia might be prevalent. And then we have dementia due to reversible causes. Vitamin B12 deficiency is a common cause. We have a dementia due to hydrocephalus, where there's more fluid in the brain. We also have depression, and I will talk about some of these in the next few slides. It's depression in the elderly is one of the things that are unnoticed and untreated. Dizziness. Dizziness, on the other hand, is mostly due to multifactorial. Dizziness is a complex issue, and we try to figure out what causes dizziness. Malnutrition, falls, frailty, gait disorders, incontinence, and functional dependence. So the doctor has asked me to also introduce some Urdu in my talk, and that's fine. The other thing that we try to use is vision and hearing. Vision is both important aspect. We have our five senses, and the information comes to our mind through vision and hearing. So it's very important that we try to introduce vision and hearing in our clinics, in our regular assessment of the geriatric patient, to make sure that their vision and hearing is checked, and whatever can be done to fix it is done. So visual impairment from cataracts, glaucoma, macular degeneration, and abnormalities of accommodation widely are usually they worsen with age. So what we try to do is make sure that we have a system in our clinics. I'm talking about a geriatric clinic, where they would make sure that they start with checking the vitals and checking the vision and the hearing. You'd be surprised, there are so many people who cannot, who have not got their hearing or vision checked. Difficulty with driving, watching TV and reading may uncover the deficits. So if you have to ask the patient, how is his driving? Can he see well? Can he read okay? So those kind of questionnaires can be used in the clinic, and they will tell you exactly what the deficits the patient has. Unless you do these things, you would not be able to figure out. The high prevalence of hearing loss with associated depression and withdrawal from social activities. So due to the hearing loss and problem with vision, the patient starts to withdraw from social activities, friends, and that exacerbates their or starts their depression or their dementia. Nutrition, we have a nutritionist over here, and they will probably talk in detail about nutrition. But poor nutrition in the older adults may reflect concurrent medical illness, depression, dementia, inability to shop and cook, inability to feed oneself, or financial hardships. Unintentional weight loss of greater than 5% in 6 months or a low BMI suggests poor nutrition. So by checking the weight, we can kind of tell that what is going on with the patient in terms of the nutrition. And unless you identify the problem, you would not know how to deal with it. Medication assessment, one of the most important things. The first time I see a patient, all I do is check their medications, because most of the time, problems that they come up with are due to medication side effects. You would be surprised that the medication side effects are so many, and a lot of times, instead of identifying that this medication is causing a side effect, we put the patient on another medication, and so forth. Polypharmacy is the term that we use, and it causes so many adverse reactions. Treatment failure may be related to medication adherence. Financial issues, fear of being over-medicated, or lack of understanding of the need for medication. So you would be surprised that you tell the patient that he needs to be on this medication, but they would not take the medication due to fear of side effects. They feel that they do not take the medication, and the main thing is that the doctor has not explained to the patient and has not taken the time to explain to the patient that what is this medicine for. So it is very important that time is our power, and unless you take the time to explain to the patient, he would not be able to adhere to the medication. Cognitive assessment. Cognitive assessment means memory testing. So memory testing is an integral part of a geriatric assessment. And what I mean is that the prevalence of dementia doubles every 5 years after the age of 65. Memory testing is an integral part of annual wellness assessment. There are different modalities that we use to check the memory. Mini mental status exam, St. Louis mental status exam, Montreal cognitive assessment are different modalities that are used, and these are tests that we give to the patient in the clinic, and that way we check what is this patient's mental status in terms of cognition and memory. And so the mini cog test is very, very easy, and we do it all the time. So what we do is we ask the patient, we tell them 3 words to remember, we tell them to draw a clock, and after a minute we ask them if they can recall those 3 words, or we ask them to draw a clock, and you'd be surprised that they would not be able to draw a clock. That tells you that this paves the way for further testing. Further testing is done by what we call as a neuropsych testing, which is done by a psychologist. And that is where we try to identify what stage this patient is, what medication should be used. Is it time to start medication, or is it just time to identify that this is what something has started and it can get worse over the period of the next few years. So the physician, the patient, and the family should start planning for that, how to take care of this patient. Psychological assessment. Depression ranges from 2 to 10% in our elderly population, and the physicians do not ask about it. and the patients do not tell about it. The family do not know what it looks like, and so it just remains there, and it just uncovers itself in a worse way. So we want to make sure that we identify this problem and try to treat it the best we can. Somatic complaints like poor sleep, fatigue, increased risk of disability, and slow recovery, all of these are can be due to underlying depression. And so if you treat depression, you can treat these things too. So these are all interlinked, and it is important that we identify that. Geriatric depression scale, or a 9-item patient health questionnaire, can be used in the clinic, where you ask the patients through a questionnaire if they have any symptoms of depression, and we treat that. Recognize and manage the consequences of bereavement. Bereavement means the loss of a loved one. So social assessment, we try to consider or keep in context the ethnicity, spirituality, and cultural background of the patient, and keeping that in mind, we take care of the patient in terms of what their thought process is about how to take care of their illness themselves. Caregiver burden, safety of the home environment, and possibility of mistreating should be also kept in mind. So this is all a comprehensive care that we can provide to a patient, and it is not done by one person. As I said, it is done by an interpersonal and interprofessional team. It is more like a teamwork. It's not a one-man show over here. Visiting nurse or a referral to a physical therapist might be important. So we assess for ADLs and IDLs. So what is ADL and what is IDL? ADL is the activities of daily living. That includes bathing. We ask about these. How is the patient able to take care of himself, and can he or can he not do these kind of things? Bathing, toileting, dressing, grooming, transferring from bed to chair, and feeding oneself is the ADL, activities of daily living. IDLs, instrumental activities of daily living, include using the telephone, preparing meals, doing laundry, doing housework, shopping, finances, taking medications, and managing transportation are all IDLs. So unless you ask about each one of those, you would not know what does this patient disability, what is his disability. Assessing the older driver, it's important that we also assess that this patient can drive or this patient cannot drive, unless you want to wait till he has an accident. So acute functional decline, I'm just coming towards the end of my slides. Acute functional decline is precipitated by illness or injury, most commonly fall. A stroke, pneumonia, sepsis, and heart failure are the ones that usually call this kind of a decline, where the patient ends up in the hospital, and after that there's a continuous decline in their function. The consequences of hospitalization include hazards of immobility and hospital-acquired complications. So you can also look into those kind of things where the patient can get worse when he goes to the hospital due to these issues. So our goal is to prevent. Our goal is to prevent these things from happening to the best we can, and the only way we can do that is to identify these problems, to work as a team, and try to take care of that patient as a whole. So what comprises our interprofessional team is the physician, who is the role leader or the team leader. We have a social worker, we have a pharmacist, we have a speech therapist, a physical therapist, and an occupational therapist. So each one of these is part of our team. We can sit together and talk about each patient. When we do the home visits, that's another way. The patients, when it comes to the point that the patient cannot come to the physician goes to the patient's home and does home visits over here. And this team is going to be your team, your eyes and ears over there, who can tell us next day that this is what's going on with the patient. Also with this, what comes is palliative care and hospice. So palliative care is when the patient is having some terminal illness but is having active treatment done. Hospice is when the active treatment has stopped and the patient has a life expectancy of less than 6 months, where you're not giving any chemotherapy, you're not treating any active problems relating to that disease, but you just make sure that the patient is comfortable. So that is palliative care and hospice, and that is a separate topic. So going forward, I think, the quality of life and advanced care planning. So that is also very important, that a geriatric patient is 65 or 75 or 85, he still should have a quality of life. How do we make sure that he has that? It is going to be the physician and the family who is going to make sure that the patient still has some quality of life and it is not the end of the world. So that assessment is designed based on the physical, cognitive, and psychological and social function of the patient. We try to identify if we can help in any one of these issues over here and try to improve the quality of life of the patient. Advanced care planning is a process that supports adults at any stage of health in understanding and sharing their personal values, life goals, and preference regarding future medical care. This includes end-of-life care too. And so also we try to make sure that we ask the patient to designate a decisional surrogate. So if the patient is not able to take care of any decisions at some time point at the end of their life, they have a surrogate, which might be a family member or friend, who can help the physician in making their decisions at the end of the life. So that is when the patient loses his capacity to make decisions. So it is important that at some time point the physician asks the patient who is going to be your surrogate, or who's going to make decisions for you when you are not able to make these decisions. Now these kind of things might sound a little bit more advanced or strange or not applicable to our society over here, but let me tell you, all those things that we have been practicing in the United States, those are going to come here at some time point. As our society advances, as our people have more education, as our healthcare improves in this and the system improves in this country, we are going to have all these things. We're going to be here in the next 5-10 years. So the earlier we prepare for it, the earlier we kind of plan for it, the better care we will be able to provide to our elderly patients who are mostly neglected in our society. We try our best to make sure that we can take care of them in the best way. And so saying that, I think that's the end of my slides. I will be happy to take any questions now, or I can talk after with anyone who has any questions after this. Thank you.
Professor Amir Khan.
Yes.